Good morning, teacher and students. My name is Jennifer Almeida, and I'm going to talk about systemic therapy for metastatic renal cell carcinoma. First, we have the definition. Renal cell carcinoma, also known as renal cell cancer or renal cell adenocarcinoma, is the most common type of kidney cancer. About 9 out of 10 kidney cancers are renal cell carcinomas. It's the most lethal neoplasm among urological tumors, since cancer-specific mortality is around 35% at 5 years. If detected early, RCC is curable by surgery, although a minority are at risk of recurrence. Increasing incidental detection and an aging population has led to active surveillance as an option for patients with small renal masses. RCC is heterogeneous and comprises several histological cell types with different genetics, biology, and behaviors.
Renal cell carcinomas, or RCCs, are the most common type of malignant kidney cancer in adults, generally affecting older men. Unfortunately, RCC is often considered a silent cancer because symptoms don't typically get noticed until the tumor has grown pretty large. Renal cell carcinomas form from epithelial cells in the proximal convoluted tubule of the kidney. And this is the section of the nephron that's usually located in the renal cortex, the outer rim of the kidney. The most common type of renal cell carcinoma is composed of polygonal epithelial cells, which have funny angular shapes with at least 4 sides, and are filled with clear cytoplasm full of carbohydrates and lipids. And it's those lipids that give the tumors their yellow color.
Sign up for a free trial today and watch the full video on osmosis.org.
About CRC. The natural history of CRC analyzing small renal masses has shown that this neoplasm has a low annual growth rate and low metastatic capacity. Now we have applications in medicine. Systemic therapy. The multi-target tyrosine kinase inhibitors TKI, axitinib, pazopanib, sorafenib, and sunitinib inhibit signaling cascade activated by peripheral membrane receptor tyrosine kinase like the VEGF receptor, which stimulates proliferation, cell survival, and angiogenesis.
Currently, in localized kidney cancer, the treatment is still absolutely surgical. We still don't have a clear steer on whether or not there is going to be any benefit to adjuvant treatments in kidney cancer. We're getting some signals from some of the trials, like the S-TRACK study results that have recently coming out and showing us that there is a possible advantage in terms of progression-free survival to having sunitinib therapy. But that hasn't been mirrored across the board with a couple of the other studies that have reported. So we await a little bit more information there. Certainly isn't standard of care at the moment. So still in localized disease, the standard treatment is to undertake surgery. In terms of metastatic disease, the landscape is changing somewhat. Still, first-line metastatic disease is treated largely with systemic therapy, with tyrosine kinase inhibitors still being the standard of care. But interestingly, we're now getting a large number of options in second-line treatment of metastatic kidney cancer. And most excitingly are the immuno-oncology drugs, the T-cell checkpoint inhibitors that are coming through, and now there is a place for their use in second-line therapy.
In the case of pros and cons, for pros, prior to this advance, patients with MRCC were left with relatively few options, as MRCC is known to have low response rates to traditional cytotoxic therapy, with greater than 70 agents being tested and response rates less than 10%. Vasoendothelial growth factor and VEGF receptor are two targets that have been exploited with results that have revolutionized treatment for MRCC, as seen with sorafenib, sunitinib, pazopanib, and bevacizumab. Additional therapeutic options with temsirolimus and everolimus, both of which have shown that potential to provide a survival advantage in patients with MRCC. The sorafenib showed that patients who received the drug had a median progression-free survival of 5.5 months. Sunitinib showed a higher objective response rate than that seen in those treated with IFN alpha. And in cons, however, the primary endpoint of the studies were overall survival, and sorafenib failed to demonstrate superiority. The most common adverse events associated with sorafenib include diarrhea, rash, fatigue, and skin reactions and the hands and feet. Hypertension and cardiac ischemia were rare serious. With sunitinib, there is a higher rate of grade 3 or 4 treatment-related fatigue experience in the patients treated with IFN alpha. However, patients in the sunitinib group experience more frequent diarrhea. Issue apply in Ecuador. In Ecuador, they create management protocols for it. These are categorized as chronic and that there is a higher percentage of male patients with this type of cancer. A cross-sectional study was carried out. 37 medical specialists in oncology were included. Clinical of Ecuador, to whom a survey was applied that was developed for this study during the year 2016. It was structured in topics of knowledge of diagnosis and treatment and perceptions of access to medicine. Knowledge about the decision of systemic treatment. 64% of professionals mentioned that they use a multidisciplinary team before starting treatment systemic. A low percentage, 5%, do so throughout a case presentation between peers, and a significant percentage, 29%, started personality. Knowledge about the treatment of metastatic RCC, first line, regarding the drugs that have shown effectiveness in the systemic management of metastatic CRC of cells cleared in patients with good or intermediate prognosis. All physicians respond to sunitinib. It is mentioned as first-line treatment in patients with a poor prognosis, 62%. and to tensirolimus 38%. All doctors mentioned having experience in their clinical practice with mainly sunitinib. Finally, we have the conclusion. So far, the molecular biology underlying cancer growth and control is a field of considerable ongoing research. In MCRC, research has focused on TKI and mTOR inhibitors, which have improved overall patient survival, but with limited prognosis. In short, we can say that progress is very rapid in order to be more directed against cancer in systemic treatment. And that's all. Thank you for seeing the video.